know where to start. Hello, I'm Dr. De Leon, a physical medicine rehabilitation specialist. I'm making a series of videos to help out in the field, out in the primary care setting, doing those initial evaluations. Today the topic is going to be back pain. I started my career as emergency practitioner as a combat medic in the Army, then became an emergency medical technician in New York City. Eventually went to the Military Medical School, Uniformed Services University in Bethesda. Became an EMT course director several years out at Fort Campbell. And I've been teaching medics, medical students, primary care residents, and nurse practitioner residents, nurse practitioners over the years. All right, and I want to continue teaching, so please subscribe. I've got a series of videos already out on vital signs, cranial nerves, spinal cord injury, and we're continuing with back pain. All right, so this is more tends to be the non-acute, but it would also include acute in there for a reason. So I can take everybody who presents with spine region pain and put them into one of 6 categories. All right, so this is an audience participation. All right, so I'm looking for what is one of the reasons, or what are some of the reasons somebody might present with spine region pain. Not the mechanism of injury, but what's the diagnosis?
Musculoskeletal, sir.
Musculoskeletal. MSK. That includes muscle injuries, ligament strains, herniated disc, arthritis, bursitis, all right, degenerative disc. We lump it together because we treat it the same, and we'll come back to that. That's the largest group among all 6. All right. So before we spend a lot of time on that, let's try to figure out the other 6. If you go to the doctor, what's the worst word that they can say to you as a cause of why you came in?
Cancer, sir.
Cancer. Very good. You guys are geniuses. So cancer tumor. All right. In our young healthy group, 20 to 50-year-olds, otherwise healthy person, if I x-ray everybody that comes in on first visit, all right, to see if they have cancer to the spine, I will cause a cancer before I find a cancer. And we'll come back to imaging and when it's appropriate, and we'll come back to that. But a 12-year-old who doesn't fall out of a tree doesn't complain of back pain. So a 12-year-old who complains of back pain gets $1 million workup because they're cancer to proven otherwise. You start getting a little mature in your body, such as myself, 56. If I start complaining of spine region pain, cancer happens in my age group. In fact, in my family, I'm either going to live to 100 or die of cancer. Those are my 2 choices. So you start getting a little more mature, you start worrying about cancer tumors in that age group. All right, but for the majority of that working age group, young healthy adult, you're not worried about that. That's not to say if you have a 35-year-old diabetic, that's not a young healthy person, or a 28-year-old lupus patient, that's not a healthy person, you're going to start doing that workup on first visit. All right, and we'll spend a little bit of time on that. All right, so we've got 4 more. What else can you guys come up with? What else do you think?
Neurological?
Say it.
I was like, maybe neurological, sir?
Neuro. So we have neuro, and that gets into our spinal cord and things like that. We're going to spend some good time on these 2. Because that's where the majority of people coming with spine region pain, your bread and butter is going to be between these 2, and how to sort that out. So that's your nerve irritation injuries. All right. In the case of lower back, there are lightning bolts in the leg, spinal cord injury, things like that. We'll come back. So we got a couple more. So let's go to our patient from the trauma conference the other day right? What did the medic do on the scene? What was the first thing they did? Guy fell off 6 feet, 8 feet onto his face, got knocked out. What did they do with the scene? C-collar, spinal mobilization. We don't know if he has a nerve injury yet, but we want to make sure he doesn't get one if he doesn't have one already, so why are we putting a C-collar on?
Keep him straight and still, sir.
All right, so we want to stabilize the spine. So we have an unstable spine. So as ortho says, bone broke, knee fixed. So unstable spine. All right. So we've got 2 more. All right. And can you do me a quick favor? In my office, in the little bag, is my spine model. Thanks. So let us use our x-ray vision as we look at the spine. Okay, we got skin. All right. We get past the skin, we see muscles, we see bones, we see ligaments, we see disc, we see joints. So all of that is covered by these 4. So what else is there that could be causing spine region pain that's not one of these 4? It's not their bones, it's not their muscles, it's not their joints, it's not their disc, it's not their nerves. But they come in complaining of, I got pain in my back. What else could cause that? This is where we start playing our practicing medicine. It's when we really start thinking. So what don't we see? If you keep using your x-ray vision and looking deeper, what do you see? Say, Ms. Ball? Thank you.
I'm not sure.
So we're looking past the muscles, we're looking past the bones, we're looking past the nerves, we're looking past the joints, past the disc. What do we end up running into? As you look at me, what do you think you run into? Woke me up 2 ATs ago at 2 in the morning, and the pain was here, and it radiated down.
Appendix?
So, innards. So, referred pain. So, nothing's wrong with my back, but I got pain in the back. In somebody who's, again, 20 to 50-year-olds, who's going to present with a kidney stone, they're also going to have nausea, abdominal pain, blood in the urine. If they got appendicitis, they're going to have abdominal pain, nausea. If they're going to have a stomach flu, they might have diarrhea. You know, depending how bad it is, E. coli, they may have blood in the poop. All right. If they're having 35-year-old having pneumonia, something like that, they're also going to have chest congestion, cough. So they're not going to only have back pain. Is it possible to have something wrong with your innards and your only complaint is back pain? That is possible. It's highly improbable. But when I did primary care, everybody that came in with back pain got a belly exam. I did find one case of a guy who had incompetent ureters, so as the urine came down from his kidneys into his bladder, the tubes drain into the bladder, so when he squeezes, those tubes supposed to be crushed off, and that way the urine doesn't go backwards, it goes out. His didn't, so his urine, every time he peed, was squirting back up against his kidneys, banging against his kidneys, started the kidney damage, and he presented with back pain, and that was his only complaint. He had also seen physical therapy multiple times, had been to the spine specialist, said nothing wrong with your spine. He was an athletic, 28-year-old male, staff sergeant in the Army, you know, big into PT, physical training, so I knew he wasn't a wimpy person, it had to be something else, so I started thinking, what else could it be? And I started looking and I found that it was kidney, so we have to always consider that. But again, in our 20 to 50-year-olds, healthy people, it's highly unlikely to have something wrong with your innards without other complaints. But again, a 12-year-old who didn't fall out of a tree, who complains of back pain, you need to do the $1 million workup. You need to be looking for the cancers, tumors, the other things. You get the mature person, all right? It could be a heart attack in someone in their 50s and their only complaint is back pain, especially females. You've got to consider other things. You can't just go, well, it's back pain, it must be, you must have a herniated disc or something, or arthritis in your back. That's the only reason you have back pain. Now you got to think, what else could it be in this person who's not in that young age group where you just don't see those things without other symptoms. All right? And now we've covered, we've got their skin, we've got their muscles, we've got their bones, we've got their nerves, we've got the joints, the discs, we've covered their innards. So why else might somebody complain of pain? If none of those things are wrong. Nothing wrong with any of them. It goes to our conversation earlier. All right. It is unfortunate that a lot of people were raped, abused as children, traumatized. Call it ACE, adverse childhood events. The pain of those experiences must come out. And until that person learns how to cry, it will come out in muscle aches and pains. In addition, even if you have something wrong with you, I injured my back, I hurt my toe, whatever, that pain signal is going to travel up the nerves to your spinal cord, splice, go up your spinal cord, through your brainstem, to your frontal lobe and say, ow. Now, we're going to use a stubbed toe as an example. I stubbed my toe, I have a fixed injury, a fixed pain generator, a fixed pain signal. Now, if I happen to be in the ER with my 5-year-old grandson, because I do that twisty twirly thing that his mother hates. And now I've got nursemaid's elbow. And here she comes with her mother, so it will be in stereo. And they didn't bring the insurance card, so they send me back out to the parking lot to go get it. And I noticed somebody dinged my car and didn't leave me a thank you note. Now I'm walking in and I stubbed my toe. Fixed injury, fixed pain generator, fixed pain signal. But what's the volume of that pain? Now compare it to, it's Daddy's Day. My son gets me the tool I wanted. My daughter-in-law, the grandkids, makes a little car outlining their hands and it's all cute. Best grandpa in the world, all kinds of stuff. Feel really good, spend the day with them. My lady gets me, a Daddy's Day card, and I open it up and it has a Victoria's Secret receipt in it. Now the kids are gone, the grandkids are gone. It's time to open my package. And I am on the way to the bedroom and I stubbed my toe. Same injury, same pain generator, same pain signal. But what's the volume of that pain? Way down. So you may have real pathology causing pain, but the volume can be affected by your mood. So it can be a source of pain, it can also be an aggravator of pain, turn up and down the volume, which is why in chronic pain, especially in chronic pain, we turn around and we do things like cognitive behavioral therapy, meditation, yoga, mindfulness, antidepressant medications. because we're trying to work on that amplifier at the brain stem, your mood center, to change your perception of pain, the volume of pain. So, we're going to deal with this cancer tumor referred pain question again. The young person, the older person, when do you do imaging? Well, in my young healthy group, my 20 to 50-year-olds who have no medical problems, they're classically going to be right here, the musculoskeletal group. Untreated, 90% of people with an acute back strain, acute back injury, doesn't matter if they had a car accident, they got hit by a 2x4, they slept wrong, they lifted something, doesn't matter what the mechanism of injury is, 90% are going to resolve on their own within 3 months. So if I wait a couple of weeks, if I wait 2 months and say, okay, you're in pain, I've proven nothing evil's going on, and we'll get into that in a moment. Let's manage your pain. Let's look at why you cause this, all right? So we'll get into that in a moment. But before I expose you to radiation, I'm going to give time a chance to heal you. And when you're not getting better 2 months later, 3 months later, I'm going to go, maybe you are in that 10%, and maybe you do have that rare case of cancer, or something else is going on. Because also if you have something evil going on, like you have some kidney problems or something else in your intestines, you got Crohn's disease and nobody's diagnosed it yet, and you present with just back pain, over the course of the next several weeks, month or two, you're going to develop other symptoms, and it's going to help me find, oh, you do have Crohn's. You started developing diarrhea that you didn't have before. Oh, let's work that up. Oh, that's part of your back pain. Now we can see I didn't expose you to unnecessary radiation. Now I can do the right workup. So we deal with referred pain by using time as a diagnostic tool in this group and the cancer tumors. All right, so by that time, I'll get an x-ray. An x-ray is great for screening for cancer tumors. All right. Your metastatic cancers to the spine, from the breast, the kidneys, the prostate, the ovaries, things like that, the kidneys. They're going to eat at the spine. You're going to see the mothball holes. All right, so you're going to see that. And now we're dealing with metastatic disease, so waiting 2 months on metastatic disease, 3 months, really doesn't make a difference. You already got metastatic disease. And I didn't expose everybody else to radiation. And like I said, cause a cancer before I find a cancer. So we can never be absolute in medicine. We got a better odds. What's the likelihood, going down this path with somebody that I'm going to do more harm than good? All right? And so I'll wait a little bit and then I'll find it. And if I want to super prove, like, okay, the x-rays were negative, I may give it another 2-3 months, try some therapy, things like that, see if they just take longer to heal, and then I'll get the MRI. Not to show that they have a herniated disc, we'll talk about that in a moment, but to prove they don't have cancer. Prove they don't have a tumor. That's why I'm getting imaging. All right, I'm not getting it to look for herniated degenerative disc. We'll talk about that in a moment. I'm trying to prove they don't have cancer. And I tell them that before I get the image. This is why I'm doing this. The unstable spine, all right? In the acute setting, like the guy that fell off the ladder, or the thing 8 feet from a trauma conference, all right? Our spinal cord injury evaluation, we're stabilizing everybody until we can prove that they don't have an unstable spine in the acute trauma setting. In the chronic nature, so we talked about our spine. This is a model of the lumbar spine. All right, it's a series of stacked bones. We break the spine into segments. We call the neck cervical, the chest with all your ribs thoracic. When we run out of ribs, we call the lower back lumbar. Continues into your pelvis with the sacral bone. Each of the bones is basically the same. You have a solid cylinder of bone with an arch of bone on the back side. If you line up all the arches, you create a tunnel for the spinal cord to pass through. Between the solid cylinders of bones, you have your jelly donut disc, and each of the arches themselves projects up and down, touches the guy above and below. So at each level, you have 3 joints, your 2 facet joints and your jelly donut disc. Between the arches on the side, you have space where the nerves come out, and each of the arches projects backwards and outwards for different muscular attachments. So, you have, not shown on this model, you have a piece of duct tape going down the front, the anterior longitudinal ligament. You have a solid cylinder, superglue disc, superglue bone, going down the inside, the back side of the solid cylinder. You have another piece of duct tape going down the inside. That's the posterior longitudinal ligament. You have the arches. If you go down the inside of the arch, going down inside the tunnel, you have another piece of duct tape, the ligamentum flavum. All right. If I take a bandsaw and cut these pedicles at the base and pull out the arches en masse, we call it the posterior column. Now I just have the solid cylinder with its duct tape and its disc. If I cut down the center of it like that and pull off the anterior section, that's the anterior column, and what's left is the middle column. You must be broken in 2 of the 3 to be considered unstable. So the classic little old lady with osteoporosis, all right, she gets the anterior column, starts compressing, and she starts getting her compression fractures, her wedge fractures, and they add up and they curve her spine, and she ends up with a hunchback. All right? You can have blunt trauma, and you can crack these, like this one has a cracked transverse process. Just like a rib, okay, you broke that, but the rest of the spine is stable. We're not going to do surgery for that. We're going to treat it like a rib, like any other thing. I'm not worried about that bone there. What I'm worried about is what's on the other side of the bone. There's enough force to break a rib. Did it bruise a kidney? Did it injure a spleen? Did it, collapse a lung? The rib itself I don't care about. The transverse process I don't care about because I'm not doing surgery for that. It's going to heal, or it's not, and the pain's going to go away. What I'm worried about is what's on the other side and the trauma that caused it. But I'm not going to do anything specific for that, and if you end up with chronic pain from that, we're treated exactly the same as this group here we're about to talk about. But there are people who have degeneration, and as these discs degenerate, these things collapse and they can shift a little bit, but they'll never shift so far as to become unstable. All right? You're not going to do that, all right, with a normal bony anatomy, even with arthritis and degeneration. But if these are cracked, they call them pars defects, then there's a potential now the posterior arch is broken, so I only need one of the other two to fail, and now I've got an unstable spine, and people can start slipping and sliding. And so the issue is that pars defects are very common in people who have no pain. So if you have pain and I get an x-ray and I see a pars defect, that doesn't mean it's the source of your pain. And if it is the source of your pain, I'm still going to treat it as musculoskeletal unless it's unstable. Because the unstable people need a surgeon. And I don't want to do surgery for back pain. I want to do surgery to protect the nerves and to deal with instability. And we'll talk about the nerves in a moment. So one of the classic things you do is you get flexion extension x-rays. So my spine is stacked from the side. I look at it, see how those bones are in alignment. I arch backwards as far as I can, take another x-ray, I bend forward as far as I can, I take another x-ray, and if those bones are shifting, the spine is unstable, the other two aren't holding it, and we do back surgery. And we don't do back surgery for your back pain, we do spine surgery so you won't be a paraplegic later in a wheelchair. Your back pain's probably going to get worse, but you won't be in a wheelchair. That's why you do spine surgery. All right? But if they look stable, Then I'll go, okay, you're stable, we don't need to rush to surgery. We'll treat you as mechanical. We'll do all the physical therapy, everything else, we'll see how you do. And if you still have pain a year from now or so, I'm going to repeat the x-rays and just make sure that you're staying stable over time. You might not shift much or noticeable as we do the flexion extension, but when I look at you next year, you went from a grade 1 to a grade 2. Well, clearly you're unstable because you're changing over time, and I'm not going to wait till you're grade 3 or grade 4 and a paraplegic. We got to surgerize you, stabilize you. So anything that tells us you're unstable, we need plain films to do that. Plain x-rays will tell us, all right? We don't need to get MRIs and things like that. If there's any question in the acute setting, they might get a CT, because you can just leave them on the spine board and just roll them through the CT scanners. They come into the ER and see everything, the brain, the spinal thing, and it's going to tell you if they need to go to the operating room and get with a spiral CT. But in the chronic nature, all right, you do those flexion extension x-rays, you see if they're shifting. If they are, send it to the surgeon, not for pain, but for instability. Their pain will probably get worse, but they'll still be able to walk. If it doesn't look like it's shifting, and they still have pain, a year later, 2 years later, repeat the images and see if they're shifting. If they are, you're back to, I gotta send it to the surgeon to stabilize you so you're not in a wheelchair, not to manage your pain. And if their pain goes away, hey, they're better, they didn't have surgery. So the question then becomes the neuro patients. Because again, everybody else gets thrown in here. You're not referred, you're not psychogenic, you don't have cancer tumors, you're not unstable. So we're trying to determine, this is the two big categories, neuro versus musculoskeletal. So neuro, someone with a nerve irritation injury in the lumbar spine, the pain is going to radiate into their legs. The most common single level. I'm going to give you a couple of choices, we'll see what survey says. So the lumbar spine is L1 through 5. The sacrum's S1 through 4. We number the nerves by the bones they're around. So let's say this is L3, L4, L5, then you get into sacrum, S1, and above this I have L2 and L1. So the choices are L1 through L5 versus S1, which is the single most common injured nerve in the spine, irritated nerve in the spine. What do you think? S1, S1, any other votes? L4?
4 or 5 maybe?
Pick one, 4 or 5?
4.
4, everybody missed it. Everybody hit right around it. L5 is the single most common injured nerve, all right? And the pain of L5 will leave the lumbar spine, cross into the buttocks, become part of the sciatic nerve. The sciatic nerve doesn't exist till multiple nerves come together in the pelvis, go down the back of the leg where the sciatic nerve splits, so it's no longer the sciatic nerve. The perineal or fibula branch, we're trying to rename it, is going to go around the outside part of the calf into the top of the foot. The second most common nerve irritation injury is what level? And I'll tell you it's either L4 or S1. Survey says?
Oh, Dr. San, he said L4.
L4. So you're changing your vote.
Go with S1.
S1.
Just have that position.
All right.
4, right?
So we got 3 L4s and 1 S1. Ms. Ball, you're the winner. We're in S1. S1 pain fibers are going to go from the buttocks into the pelvis, become part of the sciatic nerve, go down the back of the leg, and when the sciatic nerve splits, it's going to become the tibial nerve and come down the back of the calf into the medial ankle, into the bottom of the foot. Between those two, L5 and S1, you are over 90% of nerve irritations injury in the spine. So the majority of patients who have nerve irritation injury are going to have lightning bolts down the back of their leg, and that's why they use the word sciatica. Doctors use it, patients use it. It's wrong. It's not sciatica, because sciatica specifically means the sciatic nerve, which means the nerve is injured or irritated between the butt and the back of the leg. So if the injury is happening here, it's sciatica. If it's happening in the back, it's a radiculopathy or radiculitis. It is not sciatica. I'm a perfectionist on the terminology. So we're talking that. And the next most common is L4. So if you add an L4 to the L5 and S1 incidence, now we're over 98% of nerve irritations, injuries in the spine are going to be one of those three. You get to L1, 2, 3, almost never injured, and anytime you get pain in that distribution, it's going to be in the anterior thigh, and it's actually going to be a pinched nerve across the waist, lateral femoral cutaneous nerve, neuralgia paresthetica. It's not going to be from the back. It's almost never from the back when they have anterior lateral thigh pain. It's always neuralgia paresthetica, pinched nerve. Here, where those skin fibers, those pain fibers are coming together to form the lateral cutaneous nerve around the waist and then come into the thigh. You don't get S2 or below in the absence of trauma or a cancer tumor, because it's a fixed bone canal, so there's nothing to move, shift while you move around. Whereas L4, L5 disc are to degenerate with age. In fact, that's part of the normal aging process. If you take all the 60-year-olds who have back pain with nerve irritation, lightning bolts down their legs, and you take a comparable amount of 60-year-olds with no pain, no irritation, no injury, nothing wrong, and you MRI everybody, everybody has arthritis in their spine, everybody's got degenerative disc, everybody's got stenosis. So everybody's got it, why doesn't everybody have pain? Because arthritis is part of the normal aging process of the spine, doesn't mean it has to hurt. So the presence of it doesn't mean you do, that is why you're in pain. That's why you don't get imaging to look for herniated disc disc in people who just have mechanical pain, because it's not going to change your management. What you're trying to do is prove they don't have cancer. Once you prove they don't have cancer, you're treating exactly the same. The neuro people, what you're doing is you're getting imaging in these people, and you're getting imaging on first visit because now they have a nerve irritation injury, because you're trying to prove that it is just due to a herniated degenerative disc and not due to cancer or tumor, because now you've got nerve irritation injury. So if they don't have lightning bolts, they're mechanical. I'm not imaging them if they're young and healthy. If they have lightning bolts, then I am going to image them on first visit. Oh, by the way, L4, pain classically goes through the pelvis, variable, how it gets through the pelvis, but it's going to come down the front of the leg, past the knee, down the front of the shin, into the top of the foot. They're the only three that classically go past the knee into the foot. Is L4, L5, and S1. L4 going down the front through the femoral nerve to the saphenous nerve. L5 from the sciatic nerve to the perineal or fibular nerve, anyway, I don't know what you want to call it. And S1 from the sciatic nerve to the tibial nerve. So, but they're the three that go past the knee into the foot. All right. S2 is in the back of the thigh. L3 just goes down to the knee. So, now how do I tell neuro? So we're going to pause and I'm going to restart in a second, because I need you to catch me at a different angle. We don't want to start it. All right. So the cheat out in the field and in the primary care setting to screen for L5S1. If they have lightning bolts going down their legs, then the question is the nerve irritated or injured? Because the decision tree is different if it's irritated versus injured. What do I mean by that? If the nerve is injured, the muscle gets weak. If the muscle gets weak, we need to consider surgery before the leg falls off. If the nerve is irritated, all they have is pain, and we'll talk about the recovery path for that. All right? So, if I walk on my heels, keeping my toes in the air, that's my entire body weight against my ankles. And I need my tibialis anterior, my shin muscles, to keep my feet in the air. Those shin muscles are innervated by both L4 and L5 nerves. So if one of those two nerves are injured, not just irritated, injured, I'm going to have a problem doing that against my entire body weight. Walking on my tippy toes is my gastrocsoleus against my entire body weight across my ankles. To stay on my tippy toes, I need L5 and S1. So if I have an L4 injury, I'm going to have problems walking on my heels, but not on my toes. If I have an S1 injury, I'm going to have problems walking on my toes, but not on my heels. If I have an L5, I'm going to have problems with both. And since I got two legs, and classically you're only injured in one leg is going to have a problem, the other one's not, and you can tell the difference. So that's a quick check, because that gets your entire body weight. To see, can they walk across the room on their heels? All right, can they walk back on their tippy toes? And always be able to see the heels. Don't have them walk towards you on their tippy toes, because you can't see the heels and see the difference. So they walk towards you on their heels and walk away from you on their tippy toes. And right there you screened L5 and S1 against their entire body weight. You can pause it and we'll head over here. L4 equals, all right, heel walk. L5, heel and toe walk. S1 equals toe walk. All right. So that's my quick neuro check. Do they have symptoms? Are they complaining of lightning bolts? If they are, can they do this? All right. To tell me, is this something that they're having problems? I need to send them to the surgeons, get the MRI en route, because they may need surgery, or that muscle and nerve may never come back and they may always drag that foot. So we want to save it. If they can do this, then the classic person, let's take the 25-year-old who lifted something heavy in the gym, hurt their back, blew out a disc, pinched a nerve, gets a lightning bolt down their leg, all right, but no weakness. Untreated, that nerve is going to recover, 90% probability. It may take 2 years, 3 years to fully recover, and in the meantime, they're in pain. We have treatment options for that pain that avoid surgery, but their body's going to heal itself. They can do spine injections, things like that, traction, physiotherapy. To help them heal, we have nerve pain pills that can help them feel better until they get better. All right, but we avoid a surgery in someone with just an acute herniated disc. You get into my age where my discs are more degenerative and arthritic, maybe 50% probability that I'm going to heal on my own without a surgery. You get into the 80-year-olds, maybe only 15% may heal on their own without a surgery, but there's still probability they will. And we can still manage it non-surgically with spinal injections, medications like gabapentin, Topamax, nerve design medications. We can do therapy, all right? And there are people who have the arthritis starts narrowing that canal, so this tunnel that the spinal cord is passing in with age can also narrow, and we call that spinal stenosis. Stenosis, narrowing. spinal, of the spine, as opposed to carotid artery stenosis, narrowing of the carotid artery, coronary artery stenosis, narrowing of the coronary arteries. This is spinal stenosis, narrowing of the spinal canal. And these people, that narrowing is not going to give them lightning bolts per se, but can give them fatigue. So their legs just kind of fatigue out very easily. And the classic is the Walmart sign, where they get that shopping cart and they lean into that shopping cart, and I can walk Walmart a hell of a lot better than I can without the shopping cart, because when I bend forward, I'm actually opening the spine a little bit and making my nerves feel better. Those people, depending upon their symptoms, you can either consider spinal injections, therapy versus surgery. You got to see how much it bugs them, what their age is, how long the injections last, things like that. There are people who, like I had a patient last year who had recurrent lightning bolts down his legs. He would get an injection, would be cured for a year or two, and then in the middle of a cruise, the lightning bolt would come back, and he can't play on the cruise with his wife. He's got to get stuck in bed waiting for the pain to go away. He'd come out to the cruise, get an injection, he'd feel better. It's been going on for multiple years. I'm like, just go ahead and have the surgery, because we're not going to keep injecting you every 2 years for the rest of your life when you're 50. Just get the surgery and be done with it, fix the problem. All right? But everybody else, that's the musculoskeletal group. And what helps these people get better is exercise, exercise, exercise. Be happy, sleep well, don't smoke, drink in moderation, be happy, exercise, sleep well, be happy. Exercise. That's what helps this group. Doesn't matter whether it's a herniated disc, degenerative disc, arthritis, bursitis, muscle strain, ligament injury, doesn't matter. That is the treatment for this group. Be happy, exercise, don't smoke, drink in moderation, sleep well. That's what helps these people. If they're not going to naturally get better in those 2-3 months and they're going to end up with chronic back pain, that's how you manage your back pain. It is not with surgery. All right, you're going to make the back pain worse if you do surgery and they're not having a nerve injury or instability. And when a patient comes in with back pain and leg pain, I say, I can only get rid of one. Would you rather me get rid of your back pain or your leg pain? If they say leg pain, then I know we're dealing with a nerve injury, I have treatment options, we have injections, we have surgery. If they say back pain, the leg pain isn't the big deal, then they're not going to get better with surgery. Surgery has to traumatize the back, cut the skin, cut the muscles, cut through bones, chip away, put in rods, screws, all that kind of stuff, plates, artificial disc, and then you have a big hole, you have to close with stitches, the body replaces stitches with scar tissue. That's going to hurt. That's always going to hurt, so you've made your back pain worse, not better, if you don't have an unstable spine or neurological issues. All right, so that's my approach to back pain. Think of it in the 6 categories. Who do I image? Young people, old people, people with persistent pain. All right. Unstable spine, mechanism of injury, acute stabilization, chronic pain. I'm going to get my imaging, playing films, look for that flexion extension changes. If there's no changes and they persist in pain after a year or two, I'll repeat every few years just to make sure they're not staying unstable. If they ever have neurologic lightning bolts, then I want to know, are they weak and I need to send them to the surgeons first? Or is it just pain and I have non-surgical options that can help them heal? All right. If they're young or old, just like the cancer patients, I'm considering the referred pain problems. If they're in that young, healthy 20 to 50-year-olds, all right, it's in the back of my mind. All right, I may ask some symptoms. Do you have any nausea, vomiting, chest pain, shortness of breath, or anything else? And if I can't otherwise really explain the mechanical pains, I may end up doing a workup in a 25-year-old who's healthy, but for the most part, I'm going to screen them through review of symptoms and maybe add an abdominal exam, a heart-lung exam, which are simple to do, don't add anything to my back exam. And then these people, I'm more focused on, do you have chronic pain? And we have treatments for chronic pain, which include cognitive behavioral therapy, meditation, antidepressants, those kind of things, all right? But I avoid just telling somebody, hey, you're just wacko, that's why you're in pain, or you were raped as a child, that's why you're in pain, you were abused as a child, that's why you're in pain. Rather say, if you have mood disorders, that's going to make your real pain louder, so we can take advantage of treating your mood to improve your chronic pain. All right? So hopefully this helps, hopefully this is useful. Subscribe, all right? And I'll see you next time on these videos out here.